Hello, Rural Healthcare. Welcome to the NRHA Critical Access Conference. Today, we're going to spend some time talking about the current market trends we're seeing in the nursing industry, as well as the magnet model, and identify some key takeaways that you may be able to incorporate within your organizations as you're working to continuously improve your patient outcomes. First, I would like to introduce myself. My name is Danita Ross, and I am the Director of Nursing for Health Carousel. I've been a nurse for 32 years, and my first 28 years were spent in acute care magnet designated organizations. In 2017, I joined the staffing industry, being passionate about being solutions focused, and have really enjoyed my time in this industry. In 2020, I was very humbled to be named the Cincinnati Business Courier's Healthcare Hero. And also in 2021, I was just named the American Staffing Association's Emerging Women in Leadership Award. So look forward to our time together today. I've spent some time putting together some data points to help tell the picture of what we're seeing in the industry. And so we'll talk about population health, those forces of change at a national level. We're also going to do a little bit of a dive into what are the challenges over the next 10 years for nursing. And then we'll switch gears a little bit and talk more about the magnet model and how can you take those best practices from the magnet model and apply them in a rural healthcare critical access organization. So let's start with an overview and take a look at this timeline. Really this goes back almost 20 years. In 2002, the Joint Commission partnered with ACAN, and there was a landmark study that really came out and linked patient outcomes to nursing patient ratios. And so what they found was a clear correlation that the higher the nursing patient ratio was, the increase they saw in patient mortality and morbidity and failure to rescue rates. So this was an incredibly powerful study that came out. Again, research tying the care of the nurse at the bedside with the patient's outcomes. And then in 2005, the Department of Labor updated their Schedule A occupations to include nurses and physical therapists. This is really a critical piece, as this is a statement saying, that this is vital to the U.S. Nursing workforce. Bringing in non-U.S. workers in these professions will not negatively impact current U.S. workforce. So again, yet another statement telling us the signal in the radar that the shortage is really profound, and it won't be something that we'll have enough workforce internally in the United States to meet all of the needs that are being projected. And then, as the hospitals really began to have more momentum and larger voices around their quality metrics being directly tied to the quality of their nurses, there was a 2010 Robert Wood Johnson and Institute of Medicine report that came out, and really what this was for nursing was a call to action. The first big message out of this report was that nurses are going to need to practice to the fullest extent of their licensure and within their full scope. But the second and probably the most memorable piece of this report was that nurses need higher levels of education. Again, we've already correlated the patient outcome with that nursing care, and understanding the increased complexity in healthcare over the next generation. This really was a call to action for us that nurses needed higher levels of education to meet the demands that we're seeing in the industry. And then in 2018, I selected the SIA staffing industry forecast. There are many other data points if you wanted to do your own research, but we really started having deeper conversations about how critical this nursing shortage actually is. projecting over the next decade and really looking at, the percentage of the current nursing workforce that's within 10 years of retirement age. Several studies will tell you that's around 50% that are within 10 years or so of retiring. So lots of data points telling us the shortage is here. It's here to stay. It's not going away anytime soon. And then 2020, COVID-19 hits. I think this pandemic really for us demonstrated an acute on chronic situation. We had this chronic nature of this nursing shortage, and we were really trying to be innovative in different approaches to workforce strategies to make sure that we had the right mix at the bedside. And boy, did COVID-19 blow that up. What we really saw were acute crises across the United States. Is incredibly regional in nature. But I think the pandemic really highlighted for us a lot of the critical needs that we're seeing. And then, the future projections into the next decade show this continuing to grow. Most of the reports you see are looking at a growth of 3+ million registered nurse openings in addition to what we're currently experiencing as a nursing shortage. So all of these data points really help us to understand the trends in the market and the critical nature of what's at hand for us as nursing leaders. So to further the point, this slide I like to call the loss of wisdom slide. As the U.S. is rapidly losing experienced nurses, it's presenting yet a secondary challenge for us. So on the left, this graph represents the years of wisdom at the bedside that we're experiencing loss in. So for example, if I had 50 years at the bedside and you had 50 years at the bedside and the two of us retired at the same time, that would be a loss of 100 years of experience. And we all know the critical thinking and the clinical reasoning that comes with those years at the bedside. So what the statistics are telling us is that over the course of the next decade, we are going to experience a loss of over 2 million years of nursing wisdom. And so what that leads us to is this graph on the right, and that is the experience complexity gap. If you take a look at the gray line on this graph, that represents the acuity of care. Our patients in organizations have never been sicker. A lot of healthcare drives patients to the lower points of care or lower points of cost. So what we're seeing is those that are in the acute care settings are just sicker than they've ever been. And at the same time, we're experiencing all this loss of wisdom at the bedside. So the red bar on the graph represents the nursing workforce experience. So as care complexity is increasing, patient acuity levels have never been higher, we have declining years of experience of nurses at the bedside caring for these acutely ill and complex patients. So in fact, part of the shortage has been studied by the United States government. Peter Bearhouse and company took a look at our 9 U.S. Census regions and made some projections about the gaps in available RN FTE and the anticipated growth for RN FTE across these 9 census regions. So I'm just going to take the mountain region, for example. If you look there on the right side of the graph, that is that lighter green color. So based on this study, they have projected their need for RN growth FTE is going to far outpace the availability of FTE RNs to take those positions. And so again, I think this speaks to the maldistribution that has been projected and that we're seeing play out currently and will continue to play out over the next decade. So basically there will be portions of the United States that experience this shortage much more deeply than other sections of the United States. Again, remember, hospitals are making the statement of their quality through the strength of their nurses. This graph takes us back to that Robert Wood Johnson IOM report in 2010. It's been studied and it has been proven. The level of education of your registered nurses caring for your patients directly correlates with those patient outcomes. And boy, aren't we seeing it, right? Look at this graph. The blue line represents the increase we're seeing in nurses seeking and obtaining bachelor's degrees. So I think that's an important point to make as we're looking at all of the different forces at play. So future nursing challenges. I think at this point it's important to take all of these data points that we've talked about and put it together to tell a story. Again, we're experiencing incredible years of wisdom loss at the bedside. Hospitals are not only trying to recover the loss of people in the workforce, but they're also trying to recover that loss of wisdom. Again, from now through 2030, the projections are over 2 million years of experience that we're losing at the bedside. So crystal ball, what do the next 10 years of nurse staffing look like? This is an incredibly complicated graph, but I think it's important to walk through this. I don't think there's ever been a time in our history in nursing that we have had so many different generations present at the bedside. So, just by sheer age and default, the pre-boomers have retired and have left the bedside. The red line on this graph represents your baby boomer generation, and you can see from now through 2030, there's a marked decline of the baby boomers leaving the workforce. These are those projected retirements that we're taking a look at in the nursing workforce over the next 10 years. And so as the baby boomers are exiting the bedside, you see an increase in the Gen X generation. Your Gen X workforce really are your senior nurses now. These are the folks that are typically out there running the ship. They're in your leadership positions, making a lot of those crucial decisions, and really part of the engine that drives your organization forward. And then if you take a look at the purple line, that represents our millennial generation. So look at that upward trajectory. By far over the next 10 years, they are going to be the highest volume of our workforce. And so, I say all of this to say, I think it's important as an organization to understand this shift of generations at the bedside and to make sure that your organization has been innovative and pivoted to make sure that your recruitment and your retention strategies, your organizational policies are focused toward the generation that represents the most of your population. Intrinsically, we know every generation has different motivators, different things that they're seeking for satisfaction. So, for me, this is a call to action for us in nursing leadership to make sure that we are really set up to accommodate the generation that's representing our nurses at the front lines, at the bedside, caring for our patients every day. So on top of all of the demand, all of the loss of wisdom, there's a real cost associated with nursing turnover. I think let's just all agree that it's expensive. I've put some stats up here for you. You definitely can do a quick Google search and find your own stats. You can plug into your own organization and understand your specific cost of nursing turnover. But what a critical resource for us There's never been a time, I think, that it's more critical not only to attract nurses to your organization, but to retain them. You know, they're a precious commodity for all of us, and they're worth saving. And so, you know, that's really going to pivot us into looking for ways not only just to attract talent into our organizations, but how can we retain them? The cost is just too high not to consider that. So I want to pull this all together in this slide, and this really is something that all of these data points come together to create this picture. You know, we have the multiple generations at the bedside. We have maldistribution of nursing shortage, so we have some folks feeling it much more acutely than other organizations. And you know, we've thrown a pandemic and natural disaster and crisis on top of that. And so all of these things really come into what I, for sure, from my chair, see almost on a weekly basis in organizations all across the United States. And it really paints a picture of a pattern and a trend that is cyclical and repeats. And so I want to walk through this and share this with you to pull all of this together. So, you know, you have units that are experiencing increased turnover, you know, and we all know that that increased turnover on your front line leads to short staffing crisis on your nursing units. You know, and when folks are short staffed, that ends up translating to that 12-hour shift became maybe a 14-hour shift, or, you know, I had to pick up an extra shift, so I went into overtime this week, or I had to come in on a holiday that wasn't on my rotation. All of these things start to increase the stress levels of your staff. You know, their normal ratios are 1 to 5, and this shift they're going to have 1 to 7 or 1 to 8. You know, so that short-staffed crisis at your unit level leads to a lower morale of your team. And as your team morale begins to decrease and all of this impacts your staff, it naturally rolls right into patient dissatisfaction. You know, those call lights we used to answer within 3 minutes, because we have 2 or 3 extra patients this shift, we're not getting there for 10 or 15 minutes. And the cycle starts to continue, and we begin seeing decline in our quality metrics at the unit level. This naturally catches the attention of your C-suite, right? And then that leads to some tough conversations. I've definitely been on the receiving end of some of those. And when you have those tough conversations with your leadership, that naturally leads to your nursing leaders having to have tough conversations with this already stressed out staff. And so these tough conversations on a team that already has low morale and is really just kind of working on fumes leads to increased turnover. The cycle just continues to repeat itself. You know, this leads to real labor shortages. It leads to cost for your organization. It leads to a decline in the care that you're able to provide for your patients. So, you know, this repeating pattern, I think, bears watching. I think it's important to assess your units and look for any of these components of this repeating cycle, lean in, identify where you can provide support to stop that cycle, to try to save resources and keep your quality metrics intact. So now let's shift gears again. I want to talk a little bit about the role of U.S. healthcare regulation and the magnet model. So there are 2 really big mechanisms for change, I think, that have impacted caregivers at the bedside the most. The first one is the Joint Commission, and the second one is the magnet model. Both of these organizations have brought regulations, rules, bedside culture changes that we've seen incredible impact, not only from a nurse satisfaction perspective, but from quality metrics. So the Joint Commission, the government spends trillions of dollars each year on Medicare and Medicaid. And for that spend, they are looking for certain requirements to be met, just as you and I would, right? If we were spending a lot of money on something, we would have some specifications for return on that investment. And so the Joint Commission is the oldest and the largest accrediting body in the United States. Are they the only company that does this? Absolutely not. Are they the most common? Absolutely yes. So we see them in the largest majority of organizations, and really they're the mechanism by which the government has selected to make sure organizations are audited, to make sure that all of those quality initiatives and those rules and regulations are really being followed to a T, to ensure the most safe and quality care possible. Another hospital statement, again, going back to hospitals making their messaging around the quality of their nurses, speaking to the quality of their patient care, enter the Magnet program. So ANCC has this Magnet program. They initially started in 1994. There were 14 forces of magnetism. And in 2007, 2008, they scaled that back and really brought it down to 5 more manageable best practices in the Magnet model. But ultimately, I think what's important and really the basic tenet of Magnet is those closest to the work have the best solutions to the problems that they see every day. This, in fact, is proven by research. It is tried and true. Organizations that provide autonomy to their nurses. The nurses have roles and decisions that are made in the care they provide, in the environments they work in, magnetize those nurses, and they see increased retention rates and increased quality metrics, not only from the nurse satisfaction, but patient satisfaction and outcomes. So let's go a little bit further and let's walk through the model, each piece, and talk about how you could apply some of these best practices in your organizations to help increase retention rates and address some of the challenges that we're seeing. Ultimately, at its core, the Magnet model is management by measurement. In fact, they would probably go as far as saying, if you can't measure it, if you can't come up with a number from this, is it worth doing? So it's important, to look at the core of Magnet, and it's really based around those empirical outcomes. How can we show that we've demonstrated improvement? So again, the basic tenet of Magnet is structural empowerment. Those closest to the work have the answers. So, where are you making time in your day and time in your team's structure for them to come together and have those conversations and brainstorm about the problems at hand? This really looks like a shared governance model, making sure that you have set up time and space within your organization for the folks providing the care to come together and talk about your fall scores, your quality metrics around CLABSI and CAUTI or nosocomial infections. So, have them involved in understanding what are our current problems, what's our current scorecard look like, how can we make improvements at the bedside to elevate our practice and improve quality. All of that structural empowerment really becomes important from a retention strategy. Again, as we mentioned, the literature is incredibly clear that when nurses have a say in what's happening in their units, they really increase engagement and satisfaction with their organizations. And all of this really will lead to these created structures, the shared governance model where your teams are empowered to have a voice and make decisions, leads to a transformational leadership change within your units, right? We've moved past now that parental model where we tell them what the best answer is and just to go do that. Which again, the literature tells us there's lower levels of engagement with that. And we've pivoted to a model where we're saying, hey, nurse, you are empowered to look at this process, look at these policies and procedures. They are going to know the answers 9 times out of 10 on how to do it better. If there's become a gap in performance, they are going to have insight that you may not have. And so empowering your teams to be part of the solution really will, challenge you to lead at a different level. You're giving them that autonomy and you're saying to them, hey, I'm going along with your decision. We're going to partner together. We're a team in this. And that really is incredibly powerful. And what that leads to is new knowledge, innovations, and improvement. So let's just say you're looking at your fall rates. Your team gets together. They're trying to understand why you've had such an increase in your fall rates. One of the first things they're going to do is look in the research, right? What are other people doing? How are other people in our industry solving for this problem? And then they will start to implement some best practices that other organizations have seen high levels of success from. The other thing this may lead to is just new research, right? You may have a specific issue or quality concern that nobody else has anything in the literature about. So this opens the opportunity for your teams to begin to do some research and help develop new protocols to help other people that are in the same situation improve quality, improve that fall rate, improve those infection rates on your units. And this leads to an exemplary professional practice. These best practices, not only are shared from organization to organization, but again, puts you in the driver's seat of being able to conduct your own research. And so, when you've put structural empowerment in place and you've got shared governance teams, you have that grassroots effort on your nursing unit. Your nurses are making the decisions about the impacts at the bedside and the care they're delivering. You as that transformational leader are along on this journey with them and you've empowered them. You're collaborating as a team and you're developing new knowledge and improvements. And really when all of this comes together, what you see is that outer rim, that blue circle, the global issues in nursing and healthcare. And so you become part of a global community that's sharing best practices, and you've developed your own product of nursing that others are seeking. There may be organizations reach out to you and say, hey, how did you get to this incredibly low level of falls on your nursing unit? So it really improves your product, improves your outcomes, and it magnetizes your nurses. Nurses that are invested in, they have a voice, they're empowered. The literature is incredibly clear. Those are the nurses that you're able to retain, and it breeds loyalty to your organization. Whew, that was a lot. We have talked about a lot. I thank you for staying with me. My goal is never death by PowerPoint, but this has been a lot of information sharing over the last 30 minutes. I hope in the grand scheme of things, I have a couple of key takeaways that I hope you're able to take with you. First, the staffing crisis is here. It will impact quality of care, nurse morale, and turnover. It does require our attention, right? And so when we think about morale and turnover, I'm thinking about that unit in crisis and, keeping an eye on your nursing workforce, I think is critical at this point. Review of the magnet model, consider how it can be impactful at your facility. To implement a magnet model, does not always require the formal program and the financial investment in the ANCC model. Think about the best practices that exist in the Magnet model. That's structural empowerment, transformational leadership, new knowledge, empirical outcomes. If you can't see the needle has the needle moved? Making sure that you have strong structure and process in place in your organization, adopting these things that would magnetize your staff to stay in your organizations. And then, seeking to implement a shared governance philosophy using this model as your guide. We appreciate all the incredible work that you're doing in rural healthcare and critical access facilities. And I think it's been tried and true that this is a great strategy to help from a retention perspective. These engagement solutions will help lead to stronger workforce for your organizations. And so, I hope these are all things that you take into consideration as we close out our time together today. So, it's never been harder, right? Nursing is hard. On top of the nursing shortages we're experiencing today and the projections into the next decade, we will continue, I'm sure, to see natural disasters. We've had pandemics. We've had the effect of riots on healthcare and organization. And so, none of this is lost on me. And, from the bottom of my heart, I want to express my sincere gratitude to each and every one of you in the rural healthcare environment. The work is hard, we know that. And really all of this drives me and our organization to be better, to work harder, and to make sure that we're incredible partners for you, leaning in as content experts and support wherever we can to help your organizations continue to be incredibly successful and experience great nursing retention and patient outcomes. So I thank every one of you for your time today. It has been my pleasure.